Good morning, everyone. My name is Wally Davis, Vice President for North Mississippi Health Services, and welcome to our annual Managed Care Conference. Now, normally, I'm kicking off our program each year here in the Bancorp South Conference Center. But this year, obviously due to some significant changes driven by the COVID pandemic, we're going to change things up a little bit. Take a virtual tour, if you will, throughout North Mississippi Health Services and listen to some updates from our key leaders, along with some updates from the state of Mississippi. We're glad you're with us today, and we hope you enjoy the information that's being presented to you and find it useful and beneficial. So as we kick off our conference today, we will begin with comments from Shane Spees, the President and Chief Executive Officer for North Mississippi Health Services. I visited with Shane recently in the executive offices located in the East Tower on our campus. So let's transition to the East Tower and hear from Shane. Shane, we know healthcare changes rapidly. Will you describe North Mississippi Health Services and how it has evolved as the region's largest and most comprehensive healthcare system?
Yeah, well, a lot has changed, Wally. Especially during the COVID period. We've experienced a lot of change just in the last 6 months. But as a health system, we've been through a number of changes over the years, and those changes have come about to support our mission. That's the one thing that has not changed. And so our mission has been for a number of years now, our mission is to continuously improve the health of the people in our region. So we have planned and organized our system around that purpose, to continuously improve the health of the people of our region. Now that has required us to change a lot of things in the system. And so if you look at our healthcare system today, we have organized ourselves into a system or a network of providers, if you will. And we refer to it as a hub and spoke model of how we've organized those providers across the network, with Tupelo being the hub of that system, and our community hospitals and our outpatient providers who serve our communities as the spokes in that system. And so Tupelo served as the hub for many years because that's where a lot of the specialty services have been developed and concentrated. If you think about it this way, not every market needs a neurosurgery program. In fact, you want to concentrate a highly specialized and complex service like neurosurgery into one location where you're doing all of those types of cases and procedures so that you can maintain your expertise and excellence in that area. So we've designed our system of how do we best provide services that are needed in a given community, but also organize and manage our system so that that patient can get access to the right level of care by the right provider at the right place, regardless of where that place or location may be within our system. So we've worked really hard over the last several years to organize and to improve that network of providers. And the good thing about that network of providers that I keep referring to is we offer just about every healthcare service needed by our community, with a few exceptions, which means that a resident in North Mississippi or a resident in Northwest Alabama can receive most all the care they need close to home. So a lot of changes have happened, probably the most dramatic of which over the last couple of years has been the development of our clinically integrated network that we call Connected Care Partners. So less than 4 years ago, we began the work around organizing a number of providers, both physicians and advanced practice clinicians, who practice within Northeast Mississippi and Northwest Alabama, and asked them to work together and help us as a system deliver to the marketplace a unified and coordinated approach to managing quality and efficiency of healthcare. With the idea of whether you're a doctor that's employed by a hospital or employed by the clinic, or whether you're an independent practice, You're a critical role in the healthcare team, and we want to find better ways to help support your practice and help you coordinate the care of a patient across many providers. Because today, an individual physician or a provider is sharing or co-managing a patient with multiple other providers. And that can be a challenge. So we set out to develop this clinically integrated network built around delivering higher quality and greater efficiency in healthcare. And that's through supporting them with, a common electronic health record. And we're fortunate that over 70% of those participating providers in the clinically integrated network use the same Epic health record. And many more have access into the data for their patients that may reside in the Epic record. But with so many providers having access to the record and sharing that data, it positions them to even better manage that patient's healthcare needs.
So the clinically integrated network you mentioned, Connected Care Partners, how is that different than the traditional hospital or provider clinic setting?
Yeah. Well, a couple of areas that it's different. That providers, whether they're physicians or advanced practice clinicians, they may be employed by a hospital, and a lot are not employed by a hospital. They're independent practices. And if you look across North Mississippi and Northwest Alabama, there are a large number of independent practices. So these providers have chosen to run and manage their own practice. But fortunately, they support our system by referring patients in for testing and procedures and referring into our specialist. But yet they're independent, which means they're a small independent practice, and they need some support in a variety of areas. So the idea around the clinically integrated network is a provider can maintain their independence in a practice setting, but yet they can be part of a much larger virtual group, if you will, this clinically integrated network group we call Connected Care Partners, and get what is similar to a same level of support as they would get in a big practice environment. So they can get information technology and data support to it. They can get support on sharing of best practices and how to implement those best practices within their practice setting. They get access to their physician colleagues or provider colleagues around the market that they're likely co-managing patients together, so they've got access to that provider. They share protocols of what seems to be working better in caring for a particular type of patient or a condition. And so they have access to all that learning that as an independent practice, they normally wouldn't have.
So this year we've seen some significant changes in the business model for healthcare delivery systems, and COVID-19, the pandemic, has certainly led a lot of the reason for that change. One area of change we've seen is an increased demand for virtual care or telehealth. Talk to us a little bit about how North Mississippi Health Services has led the transition to virtual care.
Well, that's one of the more exciting areas of development and changes that we've experienced in the last several years and in the last 6 months. We were early adopters of telehealth. In fact, we were one of the first in Mississippi and Alabama to implement the use of telehealth capabilities. So we started 4 years ago matching a provider at one location with a patient and a provider at a totally separate physical location to deliver services that patient needs virtually. And so to give you a prime example, take a patient with diabetes, with chronic diabetes, who needs consistent management of that condition from a provider. And so with the development of telehealth, that patient, whether that patient is in Eupora or Iuka, they could go to the convenient location of their primary care office and receive a virtual visit with our diabetes treatment center that's physically located in Tupelo and conveniently help manage that diabetic condition, as opposed to having to get in the car and drive those miles, which of course takes miles of travel as well as time away from their very busy schedules or from their family. So it's been a real convenience factor. That's evolved a lot over time. And then COVID really helped us accelerate the expansion of telehealth capabilities. So expanding the number of providers offering their services through telehealth capabilities, as well as the number of patients using those services. To give you an idea of how much the use of telehealth has grown over the last 6 months. So in 2019, the entire year, we delivered about 5,600 telehealth visits throughout that 12-month period in 2019. During the month of April of this year, as COVID hit, we delivered over the same number of visits during that 1-month period of April than we delivered the entire year of 2019.
Wow.
So it shows you there's a real need out there and there's a real desire to have virtual care delivery. And so we've been able to expand the services that we offer, the number of providers that are connected in through the system, and the number of patients who are using that. And so we now offer not just the video connectivity between patient and provider. We now offer telephonic virtual visits, as well as email-based visits through our My Connection link. And so a patient, for example, that may have a sign-on through My Connection, which is the portal within our Epic electronic health record, they would have easy access to those virtual care options through My Connection.
Well, it's clear that North Mississippi Health Services' focus is indeed patient-centered. And we've heard evidence today of improving access to care, delivering high quality care, and cost-effective care. And I'm curious, do you have any final thoughts that you might want to share with us as we wrap up?
Yeah, I've got a lot of final thoughts. I'll try to keep it short, Wally. But you know, I think about what we have done over the last few years in organizing providers into this provider network we call Clinically Integrated Network or Connected Care Partners. I mean, think about over the course of 4 years, we've organized over 900 providers in this network, spanning almost every service you can think of that would be needed by a patient, covering that entire geography, that 24-county area that we serve in northeast Mississippi and northwest Alabama. We've developed those providers, and then we began experimenting with how can we best utilize that network to serve the needs of a large population of patients. So we have several years of experience now in what they call the Medicare Accountable Care Organization Shared Savings Program. So a subset of that network decided to participate with Medicare and say, let's look at how much we can improve health care and decrease the cost of health care in a defined population of patients over a period of time. And so I'm happy to say that we've got a 3-year track record now of not only improving quality metrics along that 3-year journey, but also saving Medicare considerable money each year during that 3-year journey. In the meantime, we've also taken that network and asked them to help North Mississippi Health Services manage its own health plan of employees and dependents to say, hey, you can do that with Medicare population. You know, we think you can do it in helping us as a health system save our employees and their dependents money on health care, and also continue to improve the quality of health care delivered to them. So they began several years ago working with our population of employees and dependents that work through our health plan, and they've been able to improve the quality metrics and experience cost savings to the health plan by virtue of being a well-coordinated network focused on quality and efficiency. You know, and we have deliberately designed and worked very hard over the years to pull together the components of a true healthcare system. And we've been able to accomplish that. And while it is a large system, we've been acutely focused on the quality of care and the efficiency of delivering health care over that time frame. We've made a lot of progress and demonstrated the ability to be successful in those value-based models. And we think that there's an opportunity for the broader market, whether it's a commercial insured population or it's a Medicare population, that we can help better serve them and improve the quality and cost of care. I don't normally toot our own horn as a healthcare system, but I will. We've become very good at that as a healthcare system. But our mission, vision, and values require us to get better, and we want to continue to get better. And that's what we're focused on as a healthcare system. And so I would close with this. And I'm thinking about the audience that we have out there who may be listening or viewing in as, whether you're a patient, a provider, an employer, or a payer, we hope to find a way to better connect with you and you with us. We at North Mississippi Health Services appreciate the opportunity to work with those that are in the audience. We appreciate their support over the years. And we hope that we can find a way to serve more of you into the future, because we're constantly improving and testing the work that we've done in creating this healthcare system, and would like nothing more than to serve more of the people who are listening in on the video today.
Well, Shane, thank you so much for your time and your contribution to our conference in 2020. We look forward to seeing you again next year with an update, hopefully
without mask. Let's hope so, Wally. Yes. Appreciate the opportunity.
All right,
Thank you.
At this point in our program, we wanted to stop and take just a few minutes to recognize a couple of key groups. First, to our community members. North Mississippi Health Services would like to say thank you for all you've done during the COVID pandemic. To social distance yourselves, to take the steps to be safe, including masking and hand washing. So throughout the program today, you'll see some key reminders to all of us that unfortunately, the pandemic is not over. But we want to encourage everybody to stay vigilant and take the steps to stay safe. Get outside, enjoy the weather. The season's changing. And let's do our part to be good neighbors to everyone in the community. Thank you. Next in our program, you'll hear information from Dr. Jeremy Blanchard, our Chief Medical Officer here for North Mississippi Health Services, and some comments that he shared at a recent conference.
Well, first of all, I want to say thank you, and I want to bring up one other point. I talked to my wife quite a bit about this, and I really feel blessed to be in North Mississippi Health Services, and there's a couple reasons. One, I think the system is, incredible quality, 2 Malcolm Baldrige Awards. But the second thing is the system is based on servant leadership. And when you walk into a pandemic and you're brand new and you don't know where Iuka is, you don't know where Eupora is, and people call them by their counties instead of their names, and you have no idea who you're talking to, if you're a dictatorial leadership, you will fail. So the beauty of this role and this position is that it's allowed me to be a servant leader because I have this incredible team. So as you give me sort of accolades, I guess I want to say thank you for those, and I appreciate that, but I also would like to encompass my whole team in that thought process. Relative to that transition, I was totally blessed because I actually showed up the 9th of December, and then about the 15th of January, Dr. Dick White, who had been our CMO and had been in this area for over 40 years, really is one of those faces on the Mount Rushmore of Tupelo physicians. He just was so gentle and kind in helping me understand the culture and trying to set me up for success. And then the pandemic hit, and when it hit, one of the most powerful things in my whole leadership career, which has included CMO in 2 different health systems, working for a pro football league, national consultant, critical care doc, military, is that my CEO, Shane Spees, said, I need you to lead us. And, to have that level of trust and that level of support being a new person was incredible. And then the team rose to help me be an effective leader. It isn't really that. I'm sure I rose somewhat too, and I've grown a lot, but really the team has been that incredible of a team. And I have a lot of military background and sort of system approach to things. And so what we did is we began to develop who are we and how will we respond as a system. Because we recognized any one of our hospitals alone, even Tupelo, if we interacted only from a self-centered position, we would fail. And if we fail our patients, we fail our families, we fail our community. So that contraction expansion model allowed us to provide consistent level of care across 7 different facilities with 7 different environments. It allowed us to develop trust, responsibility, caring, and support across the whole system, that covers 750,000 patient lives. So I think it's that contraction expansion using modeling that we designed based on resource capacities, our internal and external communication, and those skill sets that we have as servant leaders and that I bring to the table that really helped us be effectively weather this storm. I don't think anybody truly does super well in this setting, but the goal is to continue to provide good care to all patients. I think the other 3 tenets that come into play, and that is, one is we always prioritize the clinical acumen of the providers, whether those are doctors, nurse practitioners, all of the clinical people delivering care, over testing and some things like that. The second thing is we recognize systemness is not just a word, it's a way we conduct ourselves, and it requires listening first, speaking second, and treating each person with respect. And then I think the third thing that was really powerful is we recognize that COVID isn't just a clinical problem. I mean, as we've had to furlough people, it became a life problem, and it became a financial problem. And we've managed all of those well, and we've listened well, I think, and we've had opportunities for improvement and change. And then lastly is to be humble. And I will share with the audience, just because it's such an important northern star for me, is as a critical care doc, I have a prayer, and it's, "Dear Lord, let me be humble so you don't have to humble me. And if you do humble me, let me learn from my mistakes so I can share them with others so they don't have to feel my pain." And I think with those things in play, and being servant leaders and having expectations of servant leaders and accountability to be a servant leader, we've been able to do a great job. And I just wanted to be able to share that at the beginning of the interview.
Very good.
I think if you were going to say, well, where were the inflection points to self-actualizing systemness? Because I think we have now. I mean, although we have to nurture it to continue on. The first one is to actually figure out what were our resources from a system perspective instead of from an institutional perspective. So one of the very first things we did is created a system group, and then we developed modeling that actually looked at, if we were maxed our capacity, how many patients can we take care of from a critical care nurse standpoint? How many beds do we have that are negative pressure that we can provide care from a bed standpoint across the whole system? How many ventilators do we have? How much oxygen, gas delivery capability, how many medications, how many masks, how many gloves, because we had to be very conscious about supply management. You never saw and never will see, I don't believe, a North Mississippi Health Services person in a bandana. Now that's not a negative connotation on anybody else, but that's how great our team is in the supply chain management led by Kevin Muraski. And so that first inflection point was really saying, who are we and what are our resources? And the corollary of that is then when and how will we activate and operationalize that when we want to go to a contraction expansion model. So we designed that in January and February. We did not use that until June. So that gives you an idea of how that came into play. And in that, we had to have innovation because we never used our ICU except at the very, very beginning for the first 2 patients. We never used our ICU in Tupelo to manage COVID ICU patients. We created ICU beds in a negative pressure unit and all of the policies and protocols. So the first thing is managing those acute patients and knowing those resources. The second inflection point was really honing those. So we thought that the personal protective equipment was a natural skill set that everybody had. But it turns out it's a natural skill set that everybody thinks they have, but they don't. So we created a monitoring and education approach and really emphasized that and put a lot of our work resources into that so that we had excellent management of our personal protective equipment, and that included moving towards and then going to universal masking, how we did fit testing, etc. The third inflection point was figuring out how do we admit these patients and provide standard of care. Then the next one inflection point was how do we manage those patients and provide a standard approach to care. And then the last one is how do we disposition them. And that has really, each one of those is an active, dynamic activity that we've adjusted over time, and then we communicate out. We've created a common reservoir for all of our algorithms and a common nomenclature so people can see what's the latest version, and anybody in our system can go to that site. It's called Navix, and be able to pull that algorithm to look at that. And then we match them up with the CDC and Mississippi State Department of Health. There have been a couple places where we've been more conservative than they have at times, or where we have not necessarily fully made that change. So we still, for example, would test patients who are employees who had an exposure but were asymptomatic. The CDC is not recommending testing that person. We still would. So we continually are thinking, how does this apply to us? And then the last inflection point is how can we make this a regional? How can we make this a we instead of you and me? And that has been a very interesting journey that requires a lot of conversations with Department of Health as well as with collaborating groups, and really goes across our whole team. I've given presentations to Bancorp South. I've given presentations to Regions Bank. I've given presentations to Rotary Club. I have one with Kiwanis. But I also do every other week updates for the Japanese community, and we'll do quarterly presentations. I've done my first, but we'll do one in 2 months from now through a translator as we try to reach out. Then the other things we've done is we've done a lot of informal stuff in the background, a lot of stuff with legislators, a lot of stuff with mayors of our 7 cities, and really have school boards as well. We don't necessarily serve as their official formal medical reference point. There aren't contracts that exist regarding that, but we've definitely wanted to collaborate with them, and they've been great collaborators with us. And so that's led to, which we support, mandatory masking in different arenas, and like in Tupelo, for example, and stuff. So then that's the external. Now, the one thing to know about the external communication is it's been married to the internal. So Mr. Spies and myself have been very conscious about designing a common approach. So we have a lot of collaboration, and we use our media department and our marketing department through Marcia Tapscott and her team, and then through HR with Abby Hancock and Sandra Davis's team, to make sure that our messages are in alignment, that they're not undermining each other. And then we've developed a cadence. So for the employees, we have an employee newsletter. We also have emails that can go out, and then we've created dialogue opportunities. For the physician side of the house, which I'm directly accountable for, we have a large number of different physician groups. So we have North Mississippi Health Services medical staff. We have the North Mississippi Medical Clinics Incorporated physicians and nurse practitioners. We have our care-connected partners who are ACO. Then we have our residents, as well as are being available to any of the 4 hospital-associated clinics as well. So I do a physician update sometimes 3 times a week, sometimes once a week. It gives us the numbers, and it also tells them when we have changes. And then we create dialogue. So with the OR committee over elective surgery, with the medical executive committees, we've created COVID teams at all 6 of the community hospitals that have a physician, the chief nursing officer, as well as the administrative executive. And we do monthly updates with them, and then they share a COVID update similar to what I did for this group with each of the medical executive committees in those 6 hospitals. So that creates that monologue approach. The dialogue approach, we've actually created these things called fireside chats. So they're an educational opportunity, and they're 15-minute speakers that usually there are 3 of them, sometimes an interview. And what we've done with that is we've designed it so that we could influence what people understand about COVID. So initially it was, these are our common approaches and this is what the disease is, and then these are the chronic effects. But we've also developed patient experience and we've collaborated in other arenas, and we're doing that usually on a monthly basis. And then individual conversations. So I probably have had phone calls, individual texting with easily over 100 different physicians. And I return every phone call, every text, and have a dialogue. And what I share with them is, I don't really know the answers to a lot of these questions. I'm just trying to take this information and do it. So tell me what you're thinking. And because of all of those approaches, I think, and the incredible physician staff that we have here, I haven't had one disruptive physician in all of COVID. And I don't think there are many systems that can say that. And I think a lot of that goes out to the way that the systemness mentality we have of how do we work and collaborate together. It isn't that we haven't had challenges, that's for sure. I think the other thing that comes into play is how you operationalize your supply chain is huge. Some people want to wear masks, some people don't want to wear masks. Some people want to wear N95, some don't. The gloves change, the testing change. Some people want to be tested, some people don't want to be tested. And so managing a consistent approach and then honoring that has been really valuable. And then hearing when maybe we haven't made the right approach or we didn't communicate it and adjusting that. So I think if you look at systemness, it really has been based on these basic concepts. The first was to listen to understand without replying, without judgment. So we've created opportunities to do that. Then to share information transparently so that the other person feels you heard them and then feels valued in what you share. And then the last is to empower people to be awesome and do it in a systematic way. So we drift out of our systematic ways. We bring people back and have those conversations. We don't really carry a big stick. We carry a big earphone. And I think that's what creates respect, and out of respect comes trust. And true systemness reflects true trust. It doesn't mean you have to like the outcome. It doesn't even mean you have to like the person. But when the person speaks or the leader speaks, you know that they're telling you the truth to the best of their ability. That makes a big difference. As we know, any mask is better than no mask when worn appropriately. And so that's been a really positive thing. And then some of the stuff we've done in marketing has been shared in other arenas. So we did a 8-poster presentation of sort of humorous ways people miswear masks, and that has been well received as well. Well, okay. So we call this one the Pinocchio because your nose sticks out. We call this one the drool catcher. This one's the sling. The unicorn is this one, and it's better with an N95. Sasquatch is when you put it on backwards. This is the cowboy. And this actually came out of my trip back home, to my home, which is Montana, and I was sitting in the Phoenix Airport in Dallas-Fort Worth, watching people go by with this array of inappropriate ways of wearing a mask, and I just happened to have a creative mind, so I came up with these. So we put them on Old West posters, which we're happy to share with anyone too.
Shopping for a Medicare plan? Take advantage of United Healthcare. Whether you're turning 65 or you're looking to switch plans, your United Healthcare representative will help make it easy every step of the way. Let's talk Medicare Advantage plans. United Healthcare's options are all-in-one plans that include Medicare Parts A, B, and often include Part D as well. That means you get prescription drug coverage, annual physicals and screenings, worldwide emergency care, and you'll know your out-of-pocket spending limits ahead of time. But with United Healthcare, that's only the beginning, because there's so much to take advantage of. Let's walk through the top ways we help you get more for your Medicare dollar. 1. United Healthcare has the nation's largest network of Medicare Advantage providers, including top hospitals, doctors, dentists, and specialists. And with United Healthcare, you can take advantage of our exclusive relationship and get free designer eyewear. Plus, get name brand hearing aids with low copays.
Wow, it's too good to
2. United Healthcare Medicare Advantage plans feature personal service to help you navigate the healthcare system and get the care you need. And if you ever have a complicated health issue, you can take advantage of one-on-one support from a dedicated healthcare professional. 3. Our Medicare Advantage plans now include Renew Active, the gold standard in fitness programs for body and mind. With Renew Active, you can take advantage of a free gym membership, a personalized fitness plan, thousands of online classes, and an online brain health program from AARP Staying Sharp. And the fourth reason why a United Healthcare Medicare Advantage plan is worth stopping for a closer look? Once a year, you can have a medical professional visit your home for an unrushed health check, prescription drug review, and a home safety assessment, all at no additional cost. Finally, here are a few key facts you should know. AARP Medicare Advantage plans from United Healthcare are the only Medicare Advantage plans with the AARP name. Plus, Medicare Advantage members spend 25% less on healthcare than those with original Medicare. And over 24 million people are already enrolled in a Medicare Advantage plan. With all these people behind you, count on United Healthcare to be your partner in care, to help you live healthier. No wonder we're America's #1 Medicare Advantage plan provider. A United Healthcare representative is here to answer your questions. You can even enroll today if you're ready. It's time to take advantage.
As we share more information with you about Connected Care Partners, let's take a minute to hear 2 updates from some of our key physician leaders. Dr. Eric Dukes will share some information on the impact of COVID on our local sports, especially in high schools and community college. Then we'll transition to Dr. Brad Crosswhite, who will provide some insights on clinical efficiency and healthcare quality initiatives through our clinically integrated network.
Good afternoon again, everyone. And we are currently here visiting with Dr. Eric Dukes, a physician in our Boone Family Medical Clinic location, and also who serves as a regional medical director for our clinic corporation. Dr. Dukes, welcome and thank you for your time.
Thanks, Wally, so much. Great to be here with you today.
Well, Dr. Dukes, we've been spending a little time during our program this year for our conference sharing information related to the impact of the COVID pandemic. And you being a good friend of mine for a number of years, I know that you're a big sports enthusiast and you're actively involved in the local sports scene there in the Booneville and surrounding area. So if you don't mind, tell us a little bit about what you've seen in the high school area, especially related to sports.
Okay, thanks, Wally, for that. Yeah, I have a big sports team at the house. I have 7 children, 6 of them are boys, and so we're always playing something all the time. And I have 2 high schoolers and a junior high basketball player right now, so we're looking forward to winter, and hopefully we're going to be able to continue indoors. That's going to be the big question. But I've been really proud since this pandemic started back in the spring. The MHSA and the Sports Medicine Advisory Council or committee of the MHSA have been meeting countless times. Dr. Smith over in the Delta chairs that committee. They've done a really good job in trying to come around some guidelines, CDC and the Mississippi Department of Health, and trying to build some guidelines around which we can play safely. Trying to keep students and coaches safe, student athletes and coaches safe as they play. And I've been really proud of what they've done. As school has started here somewhat virtually and somewhat hybridly, going to school now up here in Prentiss County, they've done a really good job of symptom checking, done a good job of educating and trying to get folks to understand masking and social distancing. And I've really been proud of the effort they've put and the data they've collected. We've been watching that data all summer as they started back practicing in June. And so we really had a good foundation built and habit built for the kids as we started school. And so the data is very useful because we can use that to contact trace. It makes it a lot easier to know who was in the building or at a practice on a certain day, who they were in contact with. We have some teams that are even masking. The volleyball teams being very diligent to wear their masks. And so if they're exposing, becoming exposed at that practice, they're all really non-exposures because they're all masking. So we've really tried to educate them well and how to mitigate. And I've been really proud of what they've done as a high school at that level, and really been able to accomplish to keep kids and coaches safe. So we've started football. We're 1-1. We play South Tilla this Friday night. Unless someone gets COVID and we have to cancel the game, that's been an ongoing possibility for everybody that's playing right now in Mississippi and in the surrounding states around us, is having to move games and having to come up with other opponents at a moment's notice. But some of that's happening because of this. But we're pressing ahead and we're playing football. And so it was good to be in New Albany last week and have a little bit of normalcy in this crazy time.
That's good. That's great information, and we appreciate everybody's efforts in that regard. Now, I noticed there's been some changes in the community college sports scene, and specifically as it relates to the football season. Tell us a little bit about those changes and maybe what we can expect. And along with that, maybe share your thoughts on some of the challenges that the junior college and community college coaching staffs are facing.
Yeah, I think we're a region in Mississippi, and so we're a little bit unique in how we've handled things. We're not just a state, but we're also a region. And most of the coaches have voted and they've decided that they'll have a spring season, but some of the teams will play a fall season as well. They can have 3 games, count them as scrimmages, and still play in the spring. So at Northeast, that's what we're doing here in Prentiss County. We're going to have 3 fall games. They're geared up to be just a couple weeks in October. They've been practicing hard. We've been keeping them safe. Northeast is doing something very innovative that some of the senior colleges are doing in the Southeast. I've heard, I know Georgia Tech's doing it. They have a text message that's sent out to their students and their student athletes every day. All the employees get this text message as well, and they will respond with attestation to symptoms. So if they have COVID symptoms, they make a response. It bounces back to about 4 people in the community college, the dean of students, the athletic director, the student trainer, and they are appropriately responded to and sent to be tested if that is what they need symptomatically. If it's an exposure question, they may be quarantined and then tested at a later date. And so they've really done a great job, I think, around some digital efforts to really try to keep, again, students and coaches and teachers safe. So I've been really proud of their efforts. I think for the community colleges, it's just like any employer or any of us, really. For the senior college and junior college, testing has been the really big hindrance in playing sports. We've seen the Big Ten reverse this week. They came out this morning, and they're going to play football now. They had a lot of question of why they didn't want to play. There was a big question about a vote. But as it's come out, they thought maybe the myocarditis was a reason around why they weren't going to play. But they in the Pac-12 chose not to play when most of us in the South and in the Big 12 and the ACC played. And so it's been really helpful. And a lot of that's the hindrance around a lot of that was testing. We've seen that in even our system at North Mississippi, where we've had some supply chain hindrances where we can't get enough tests, and we have to reshape how we're testing with all the relationships we have, not only with patients that come into our clinic, but also with employers. And so it's been real interesting to me to watch this all unfold because the big key is we want to go on back to life as normal. We want to do it safely and commonsensically and try to catch people early and contact trace so we don't spread this out in a mushroom.
Thank you for those thoughts. And so we've talked a little bit about, how the school systems are responding, even a school system, a college, if you will, as an employer. Tell us your thoughts about how we as individuals maybe can manage our daily activities in this ongoing pandemic.
Well, it's a question I get every day. Really have some education to folks every day, countless times during the day if I'm seeing patients in the clinic, because we're all still real uncertain about this. Everything is not known about it. We do know that masking helps. It's been proven, and I think it's a very obvious thing that the respiratory burden is decreased if you and I are in a room with close contact and we both have masks on. There's not as much respiratory burden being put into that room. And then so I think that's one big thing that we can continue to do is mask and really not only help ourselves but help the other person as we try to take care of each other in this crazy time. I think watching for symptoms and being common sensical. Don't go to work if you're sick. Don't go to school if you're sick. If you have fever or if you have symptoms that you wonder if they're COVID symptoms, contact your physician or your provider. So I think those things, washing hands, continuing to be mindful of keeping our hands clean and away from our face, are all things we can do day to day, moment to moment, to try to help mitigate this disease and can especially keep it away from us.
Well, Dr. Dukes, thank you so much. We really appreciate all your efforts and all you do. I don't know how you find time in the day, so to speak, but thanks again for your time, and we look forward to seeing you again soon.
Thanks, Wally, so much. I'll leave you with something I heard John Gordon say yesterday. We spend our 20s, our teens and 20s and 30s trying to get to the midlife, and then we spend our 80s and 90s looking back. Both of them, as we think about them from both of those ends of the spectrum, it's the greatest days on earth. As we live them, kind of chaotic. So we just keep going and be positive, and we do the next thing we can do. So I appreciate the time to be with you, and I'm thankful that we've got football back, and we're going to have sports this year, hopefully safe. So have a great day.
Yes, sir. Thank you. You enjoy your day.
All right.
Hello again, everybody. And in this segment of our virtual conference today, we will be visiting with Dr. Brad Crosswhite. Dr. Crosswhite, thank you for joining us today. We appreciate your time.
I'm happy to be here. Thank you for the opportunity, Wally.
Dr. Crosswhite, I understand you currently serve in several roles for us here at North Mississippi, and we appreciate all you do. Not only an active practicing physician, but a regional medical director, and you serve as the co-chair for our Connected Care Partners Clinical Efficiency Committee. So, earlier during our virtual conference, we heard Shane Spees mention Connected Care Partners, and that this clinically integrated network has some success stories in managing health plan members in our area. So can you take a minute and maybe explain to our audience the value of clinical integration?
Sure, I'll do my best. We're still pretty early in this endeavor, but so far I think we have seen as a system that we've had some tremendous early success. And I think part of that comes from the value you get when you have so many members. We have over 800 members or partners, participants within our clinically integrated network. And when you get that many people involved with the same mission, who shares the same focus, who ultimately have the same aligned goals, there's a lot of power in numbers. And I think with getting that group together with so many people sharing best practices with each other, learning from each other as far as clinical knowledge and experience, I think it really has allowed us to provide care at a different level. So we're trying to ultimately provide care that is the highest quality of care possible at the lowest cost. So ultimately that increases the value of care we provide. So, through several different committees that we've developed, we've been able to dissect and look at a more granular level the types of care we provide and look at the patients for whom we care. And having so many people involved with an aligned goal and an aligned mission, I think has allowed us to achieve success early on and will hopefully allow us to continue to have success in the future.
Well, thank you for those thoughts. And, maybe putting a few numbers out there for our audience to maybe gain a little perspective. Connected Care Partners has been focused on that total cost of care you mentioned for some 21,000 plus Medicare members in our region, and has active ongoing initiatives with our own health services health plan, which has 12,000 members. Can you tell us a little bit more specifically about those efforts in delivering high quality health care in a cost effective manner?
Sure, that's a good question. I think there hasn't been an easy one-size-fits-all solution. So I think what we've tried to do over the past several years is develop a multi-pronged approach. Part of that consists of developing different committees within the Connected Care Partners group. All of those committees report to the board, but each committee has a specific task or a specific endeavor. As you mentioned earlier, I'm the co-chairman along with Dr. Joe Johnsey, who's an emergency medicine physician. We both chair the Clinical Efficiency Committee. One of our tasks that we do is try to improve, obviously, the overall efficiency of care we provide to patients. And we like to share information with our colleagues transparently. We know that in medicine, oftentimes, competition drives success. By nature, physicians or nurse practitioners or physician's assistants are competitive people and want to provide high care for the patient. So by sharing information with our colleagues, I think we've been able to promote more success. It also allows us to realize where we may indeed have some deficiencies. We may have gaps in care. For example, for preventive services, we may realize that we needed to do a mammogram on a patient that has not yet had one, or perhaps a colonoscopy on a patient. So we really try to dissect these quality metrics on which we're measured each year and break it down to a granular level where I, as a provider, know exactly the patients for whom I'm responsible, and any other member of our Connected Care Partners group would know the patients for whom he or she is responsible. So we try to provide data. I think we've become more data-driven over the last several years, and putting that data at the provider's fingertips has been very powerful at allowing us to determine what we need to do to take care of the patients within our panel. Specifically, with regard to the Clinical Efficiency Committee, we like to look at things at a granular level, as I mentioned. So what we've done is we've developed roundtables where we meet together. We haven't been able to do so this year with COVID. We've had to do a lot of things virtually, as you guys are all aware. But we've tried to share best practices through other avenues. I believe you've heard from Dr. Eric Dukes. He's also the chair of one of our committees, which is the Primary Care Collaborative. Some of the things Dr. Dukes has done is to educate fellow members of Connected Care Partners on best practices, specifically revolving some things around COVID this year, and also sharing some clinical pearls and tips to help provide good care. Going back to the Clinical Efficiency Committee, some of the things we look at a higher level are things that drive up cost unnecessarily. And in medicine, we know that one driver of cost is certainly emergency department utilization, specifically talking about unnecessary emergency department utilization. We all know that there are patients that need to go to the ER, and if our patients need to go there, we certainly want them to go. But multiple times we've seen examples where patients go to the ER when in fact that same level of care could have been delivered very easily within a clinical setting. And we have multiple clinics. We have really tried to promote access for our patients so our patients can be seen conveniently when they need to be seen. When we went back and looked at a lot of things, we realized a lot of patients were actually being seen at the emergency department during hours which our clinics were open. So we've really tried to take this data and find ways to reach out to these patients to make them aware that we do have access within our clinics for you, and we can provide the same level of care for diseases that aren't as high of an acuity level that should typically be seen in an emergency department. Another thing that we look at in the Efficiency Committee is hospital admissions. A huge portion of cost for health plans come from hospital admissions. So we look at length of stay, but we also look at hospital admissions that could have been avoided with a primary care physician's visit before the visit. Oftentimes that's the same patient that presents to the ER that gets admitted, whereas that patient could have potentially come into my office a few days before and we could have avoided that hospital admission. So we look at common diagnoses for hospital admissions and we try to focus on those individual cohorts of patients to engage them early on, to inform them, at least through our population health department, who has close telephonic contact with many of these patients, who can early alert the patient's primary care provider and say, hey, this patient's not doing well for this reason. I would like to get the patient in to see you. And by doing such, we can avoid a hospital admission. A few other things we look at within the efficiency committee is hospital readmissions. We all know that a lot of health plans and insurances are penalized, and hospitals are penalized actually for readmission. So we focus on readmission rate. We try to utilize our population health department, which consists of registered nurses, LPNs, as well as the clinical dietitian, to form a good relationship with this patient. So this person can be involved with care between visits. So we don't only have the episodic care every 3 to 6 months, but that patient is continually plugged in to a population health nurse who can help navigate that patient through the difficult areas of health care, whether that be an outpatient ambulatory setting or coming out from an acute setting like an acute hospital stay or perhaps a swing bed facility, and integrate them back and give them a safe landing spot when they come back to see their primary care physician. And then last, one of the other things we focus on is the prescribing of medications. Medicines are very expensive, as we know, especially in the United States. And we really try to focus on utilization of generic drugs when, of course, generic drugs are appropriate for our patients. Oftentimes, generic drugs can be prescribed, but sometimes only brand medicines can be prescribed, and there's not a generic equivalent. So in those situations, we understand the use for brand name medications. So what we try to focus on is generic efficiency, which is prescribing a generic medication when there is indeed a generic medication available for our patients. Because time after time, we've proven that the vast majority of these drugs are equally efficacious as their counterpart brand name medications. So those are the things we focus on within the Clinical Efficiency Committee. And then there are other committees, such as the Quality Committee, that also meets to set quality metrics. With regard to quality metrics, we've set within the clinically integrated network 5 different parameters. Some of those deal with individual care for preventive services, such as mammography or colonoscopy, and some of those deal with more disease-specific states like diabetes and revolves around checking a patient's A1C or checking for kidney disease on an annual basis. And all of this data we share transparently with our members as well, so they can see their patients and they can potentially define a care gap and then reach out to these patients proactively to fill that care gap instead of reactively waiting for that patient to come into us. So I think the transparent sharing of data in the network has been a very powerful tool and has allowed us to have some success. Sorry for the long answer.
Oh, that's very impressive information, and thank you for sharing those details. Now, switching our thought process slightly, you mentioned earlier that we've all been impacted by the COVID pandemic, and it has been and continues to be a very serious health concern situation for all of us. So I'm sure you've witnessed some changes, some impact at your clinics. Can you tell us a little bit about your thoughts on what you've seen as a physician from an impact perspective of COVID?
Man, that's a great question, Wally. I tell you, I guess nobody thought we would ever be in this situation. We started planning a little bit, prepping for this in February and perhaps even late January when we saw this happening in China, and we said, well, this could happen here. But we really didn't think it would be this big of a deal. And I tell you, since March, it has completely turned the medical world and the medical community and healthcare upside down, from both the ways we deliver care to our patients, as far as the economics of healthcare and how it's impacted health systems' financial impact and budget. So it's been a huge change, and I think a lot of times we have continually learned as this has gone on. Things have changed. They may change on a week-to-week basis. At times they were changing on a day-to-day basis. But it has truly changed the way that we reach out to patients, that we take care of these patients. We had COVID taking up a large percentage of our resources in the hospital. Our emergency departments oftentimes were full of patients with COVID. Later, our intensive care units became more and more filled with COVID. But that did not preclude the other patients that had other chronic diseases, that had heart failure, that were having heart attacks and strokes. These things continued to happen. And oftentimes patients were afraid to go to the emergency room. They were afraid to come into our clinics because they were so afraid that going into one of these places may allow them to catch this virus. So we had to quickly adapt some new methods to take care of these patients. And oftentimes it felt like we were trying to build a plane while we were flying it. But we did rapidly learn fast. And fortunately, a lot of the payors, even government with Medicare and Medicaid, have allowed us different avenues through which we can reach our patients. And one of those is actually through telehealth. We've embraced telehealth within our system. We have several options available. We can reach out to our patients telephonically. If they don't have internet access, we can just simply call the patient and do a visit through the phone. We can also do audio-visual visits, which are more of the virtual visits where I can see the patient's face, the patient can see my face, much like we're doing here with this interview. And then it allows us to look at things if we need to see on a patient. But still, throughout this whole process, oftentimes patients needed to come in for their routine blood work. If it's a diabetic or if patients are on high-risk medications, they need to have their labs checked. So we had to develop new processes for that because it would obviously defeat the purpose of having a patient do a telephonic visit, but then telling them to come inside an office to get their blood drawn. So what we developed at many of our clinics is a drive-through laboratory service. So we would have the patient drive his or her car behind our building. We would put a sign there. The patient will call that number. Then someone from our lab would actually go to that patient's vehicle with a mask and gloves and draw the blood right there in the patient's car and then let the patient leave. So that patient felt safe. We weren't skipping on any care as far as quality goes because we could still take care of the needs. We still refill the medicines, but we reached out to that patient a different way. And to this day, we're still performing quite a few telehealth visits, and we still have the drive-through service going. So for the most part, patients have really enjoyed that opportunity to have that same level of interaction with the physician, even if you're not within feet of each other in the office. They're very appreciative that we care enough about their health to reach out to them in a different manner to make sure that we're still providing the same level of care and that their health doesn't deteriorate because of that.
Well, Dr. Crosswhite, thank you so much for your time today. All the details you shared were just really great and informative. We do appreciate all you do. Thank you for your efforts during the pandemic. And hopefully next year during our conference, we can see you live and in person. But until then, stay safe.
Thank you, Wally. Same to you.
I just want to take a minute to encourage everybody, if you haven't done so already, learn more about how you can sign up for the My Connection app. It's very handy. It's something that I use routinely. You're able to check information from your physician. You can see test results. You can actually schedule appointments, all right here in your hand. Avoid those waits on the telephone call and connect to My Connection, the application. Hello again, everybody. We're here at the Community Development Foundation in downtown Tupelo, and I wanted to take a minute or two and share some key informational updates as it relates to consumers in our market who may have an interest in Medicare Advantage. Medicare Advantage plans are typically offered during an open enrollment process each fall. Individuals that qualify for Medicare Advantage coverage should enroll between October the 15th and December the 7th. If you currently have a Medicare Advantage plan where North Mississippi Health Services may be considered out of network, you'll be glad to know that we have 2 new contracts with both Aetna and United Healthcare for individuals seeking this coverage. Please reach out to your local insurance agent or broker or contact Aetna or United Healthcare at the 800 number listed to learn more information about how you can enroll in a Medicare Advantage plan. At this time, we're going to go inside and see if we can find my good friend, Judd Wilson. I believe he's got some information he wants to share with us as it relates to hand washing. Let's go inside and see if we can find Judd. Hey, good morning, Zandra.
Good morning.
I was scheduled to meet Judd here today. Do you know where he is?
I really don't know where Jeff is.
Oh, me. I know that guy's busy. Well, I tell you what, do you mind if I look down the hall and see if I can find him?
No problem at all.
Okay, all right. Thank you. Well, I wonder. Not in there. I wonder if he's in here.
Oh, I wasn't expecting any guests, but I'm glad you're here because I want to tell you about the importance of washing your hands, especially during COVID-19. Hand washing is the best thing to help stop the spread of COVID-19. They say you should wash your hands for at least 20 seconds. A good rule of thumb is to sing happy birthday twice. It didn't really do it for me. I like singing this song. Caught in a trap, I can't walk out until I wash my hands good, baby. We must go on together and wash our hands, so if I don't shake yours, please understand. So that's how I wash my hands. So wash yours, and I thank you. Thank you very much.
For our next segment, let's talk about health insurance and how you, our consumers, can access health insurance contracts who serve as partners with North Mississippi Health Services. For employers, I'm really excited to announce that we've expanded relationships with 3 national carriers, including United Healthcare, Cigna, and Aetna. So in addition to Blue Cross Blue Shield, North Mississippi Health Services participates as an in-network provider for all of these health plans. Employers seeking information on how to secure proposals should reach out to your independent insurance agent, broker, or your consultant. Next, we have an update from Aaron Sisk, the President and Chief Executive Officer for the Magnolia Health Plan here in Mississippi. Aaron will share details and updates on information related to health insurance options on the federal marketplace. Later, Commissioner Mike Chaney, our good friend there in the state capitol, will provide a few thoughts and comments from his office. Well, we're here with Aaron Sisk, President of the Magnolia Health Plan, Chief Executive Officer here for that health plan in the state of Mississippi. And Aaron, thank you so much for your time today and spending a few minutes in this new normal. And I can see you're working remotely, virtually, as am I. So welcome.
Thank you, Wally. I appreciate it. It's really a privilege to be here and be talking to you guys today. Really love any opportunity I have to get in front of the group up in Northeast Mississippi.
Oh, good, good. Well, we want to just take a minute or two and maybe pick your brain on some information, specifics related to Magnolia Health Plan. So can you share with us some details about your health plan here in the state and the products that's being offered to consumers in our region?
Absolutely. Magnolia Health Plan is a wholly owned subsidiary of Centene Corporation, large multi-product insurance company, and we're the Mississippi market. And so in Mississippi, we are a multi-line insurance company offering 3 different products in the state right now. The first one is our Mississippi Can product, which is our core product, our original product here, and that's the managed care product offering coverage to Medicaid beneficiaries in the state. We cover about 200,000 lives statewide through that product. And interestingly, about 87,000 of those are up there in that Tupelo region. So nearly half of our Mississippi Can population resides in your service area. And then we've got our Ambetter product, which is our health insurance marketplace, our Obamacare or our ACA product. And we cover about 90,000 lives statewide through that product. Of that, about 20,000 are located in your service area. And then we offer a Medicare, several different Medicare products. Our Medicare footprint was small until recently. We recently acquired WellCare, and so we picked up their business in Mississippi, which is about 30,000 lives statewide.
Outstanding, and congratulations. So tell us a little bit about how maybe the enrollment process works for these products.
Yeah, it's interesting. It's very different for each one. For the Medicaid product, enrollment, eligibility, all that is determined by the Mississippi Division of Medicaid. So an individual that's seeking eligibility for Medicaid would go directly to probably a Medicaid regional office. And I'm sure there's one in Tupelo. I'm sure there's one in several surrounding communities. And they go in and submit an application. Medicaid determines the eligibility and enrollment. And if they're eligible for the Mississippi Can program or automatically enrolled in the Mississippi Can program, at that point, they're sent over to us. I will say, interestingly, members have choice, so they choose which managed care company they want to participate in. They also, and this is the most important choice they have the choice of their primary care provider. One of the big important matters for Mississippi Can is that establishment of a medical home. And so picking that primary care provider is really critical to starting that program. If they don't, then one's automatically assigned to them.
Aaron, switching gears a little bit to the Ambetter product, can you tell our audience about that product line specifically and how it's made available to individual consumers in the Tupelo region?
Sure. Our Ambetter product is our health insurance marketplace product. It's our commercial exchange product created under the Affordable Care Act. It's designed to fit an individual's health needs and budget. It's a health insurance policy, just like you would buy out on the individual market.
So, Aaron, tell us a little bit about the cost of the product for Ambetter and maybe when individuals can actually enroll.
Absolutely. That's a complicated question to answer. The cost for the product is determined by so many different factors. A person's, and just like any insurance product, a person's age or whether they smoke or not, where they live. But it varies a lot by metal tier as well, what type of product. There's a lot of options out there depending on what people feel comfortable with from a deductible standpoint or a copay standpoint. And then the government subsidy, the federal government tax credit that's applied to the product to help pay for premiums is determined based on an individual's family income. And tax credits are available for everybody from 100% to 400% of the federal poverty level. And so that's it's been a while since I've looked at what those numbers are, but that captures most Mississippians, honestly. Interestingly, in Tupelo, in the Tupelo area, we've got about 20,000 Ambetter lives, but we have determined there's probably about 60,000 people in your region that are eligible for a tax credit. And for a lot of people, that tax credit is going to cover all, if not almost all, of their premium. And so really the only way to find out how much that policy is going to cost for an individual is for them to go online to healthcare.gov, to ambetter.magnoliahealthplan.com, go visit a local broker and sit down, do the paperwork, and enroll. I think a lot of people are shocked to find out how little they have to pay out of pocket to obtain insurance.
So any thoughts related to the impact of the COVID pandemic, maybe for individuals that are maybe currently uninsured or maybe small business owners that are looking for other alternatives?
Yeah, I think that's a great point, Wally. There are a lot of people that have either lost their jobs or had a reduction in wages, lost their health insurance coverage. A lot of those people are going to be eligible to enroll in Ambetter during a special enrollment period. That's a life qualifying event, and so if something like that has happened, even though we're not technically in open enrollment yet, which runs from November 1st to December 15th of this year, they could be eligible to enroll in the product because they've had this qualifying event happen to them.
That's great. Thank you for sharing those details with us. So, as a large employer in the state, Magnolia Health Plan has several employees. I'm certain that the COVID-19 pandemic has impacted you, maybe both operationally as well as some impact to the members. Can you share some thoughts about that?
It absolutely has. It's impacted all of us, and I love the question. How has it impacted you? And it's still impacting us, and I don't think any of us have felt the full impact of it yet, which is, like nothing I've ever seen, certainly. Back in March, we made the decision to move to a work-from-home setting, and I'm very proud to say we took 350 people that were working in an office and moved them to a work-from-home setting in less than a week's time. It took a lot of work by our local leadership, but also a lot of support from our corporate IT partners to make that happen. And I guess I didn't realize how transactional our business was. It has gone I couldn't be happier with the results we've seen. We really have not missed a beat. Even now, as volume has picked back up to near normal levels, we're still moving along quite well, and we'll remain in a work-from-home setting at least through the end of this year. From our member standpoint, provider standpoint, we've done a lot of things. First of all, we thought that it was important. There's so much information swirling around. We wanted to make sure that we were getting some accurate information out to our membership. So we've issued several press releases. We've put a lot of information on our website. We have sent out mailers to members just to let them know what's happening with COVID-19, how they should respond if they feel like they've got symptoms, that type of thing. But also reminding them to keep up with their preventative care and to maintain their current health and take the medications, make sure they're getting medications filled, make sure they're going to doctor's appointments as scheduled and as practical, because that's one thing that I'm very concerned with on the back end, is that people maybe are ignoring some of their primary care and their preventive care needs because they're scared to get out of the house or go to the doctor's office. But that could have repercussions long term that's going to be bad for them, tough on the healthcare system as well. Go ahead, Wally. I'm sorry.
I apologize. I was just thinking, I realized that Magnolia has been a leader in the state in giving back to your membership as well as communities throughout Mississippi. Can share a couple of the points related to that comment and your thoughts.
Sure. A couple of things quickly for our members. We've waived copays. There are telehealth services that were not covered, primarily in the therapy space, that are now covered. And we have issued some telehealth grants to different providers throughout the state to help link them up with their members. We have sent out to several partners throughout the state nearly 1,000 gift cards from Walmart and Amazon, and these weren't just for Magnolia members. These were for anybody that may come into a clinic and be in need of basic supplies. There were limited use cards. You couldn't go buy whatever you wanted to at Walmart, but if you needed toilet paper and could find it, or paper towels, or cleaning supplies, food, basic care, basic necessities, then that's what they were there for. We donated nearly $50,000 to food banks across Mississippi. Centene made a very large contribution to Feeding America, which works with the Mississippi Food Network. So a lot of that money came to Mississippi to help make sure folks are getting healthy meals. We sent about 5,000 masks out to members, 500 items of PPE to Child Protective Services. We are the only or the primary provider of health care for our foster care population through the Medicaid program. And so we wanted to make sure that those field workers with Child Protective Services had the protection that they need. And then we've sent out cell phones, about 200 cell phones to different providers, so that if they had a patient, not just a Magnolia patient again, that just didn't have a cell phone or a way to link to them telephonically, they've got a telephone that they can use.
That is great. Well, Aaron, we at North Mississippi Health Services, we really appreciate our partnership with you and your group. Your team is always super responsive to my requests, so I appreciate that very much. And thank you for being a great payer partner here in the state.
Thank you, Wally. Thank you for everything that you and your team up in North Mississippi, what you do for our members and for us. It's always great talking to you, and I've really enjoyed working with you. It's been about 10 years now, I think.
I know. Don't tell our age, right? Well, hopefully next year we'll get the chance to meet in person, but if not, we'll dial in virtually again. But Aaron, thank you so much for your time today.
I'm looking forward to it. Thank you, Wally.
We see you, looking out for all of us. But at Aetna, we want you to focus on something else now, yourself. Especially if you've got diabetes or cancer, a heart problem, or any serious medical condition. Because even though the pandemic has put most everything on hold, one thing you can't ever put on hold is your health. That's why we're always here to help with virtual monitoring for high-risk patients, 24-hour telemedicine to keep up with your treatment, and all the resources you need for a safe return to your doctors. So thank you for looking out. But remember, we're always here to look out for you too, because it's always time for care. Find out more about our chronic care resources at aetna.com/timeforcare.
This afternoon, we are with my good friend, Commissioner Mike Chaney, who's coming to us live from Jackson, Mississippi, in the Mississippi Department of Insurance. Commissioner Chaney, thank you so much for your time today.
Always a pleasure. Well, I think we're far enough apart. I'm going to take my mask off, and we'll still fit the governor's guidelines on this thing anyway.
Effectively social distancing. Yes, sir.
You've got it right.
Well, we truly hate we didn't get the chance to visit with you in person this year, but this year in our conference, as I had explained to you, we are conducting it virtually. So thank you for taking a few minutes to share your thoughts with us. And if you don't mind, we'll just walk through a few questions and
sure, not a problem.
See what's going on here in the state. So, Commissioner, during this time of the pandemic, telemedicine has become a necessary source of health care in Mississippi and actually across the United States. And I understand President Trump entered an executive order on August the 3rd in connection with telemedicine. Can you tell us a little bit more about that order?
Sure. The president signed an executive order with the goal of trying to improve health care in rural America, and that includes Mississippi. And it was signed with the intent of trying to help seniors and for all Americans. So it depends on how you want to look at it. But he did that by expanding telehealth and modernizing some regulations and reforming payments. And specifically, the executive order calls on HHS to propose a Center for Medicare and Medicaid Services, that's CMS rule, to extend parts of the Medicare border coverage or the broader coverage that they normally have of telehealth beyond the end of the current public health emergency. So it may go past December if we have a vaccine. And the second thing that it did, or one of the other things, was propose a payment model to improve rural health care through the Center for Medicare and Medicaid Innovation. On telemedicine today, actually, we've just now extended the telemedicine bulletin that we issued back. It's bulletin number 2020-1 that we actually issued in March. And that bulletin was extended today to go through the end of December of 2020. It was due to expire September 30th at the end of this month. And some of the providers have said they're willing, they have no problem with extending it to December 31, 2020, and that's what we've done. I will tell you that I've been pleasantly surprised at the healthcare providers that have come to us and said, that's really been a good effort by the department to expand telemedicine and telehealth, because it enables us to reach out to someone that we actually know and avoid having to have them come into the office for minor ailments and avoid contact in the COVID, especially in the COVID-19 pandemic area. So it's something that we feel has been a great benefit to the consumers of the state, and we applaud people like North Mississippi Medical Center for what they've done on telemedicine too. It's been a good experience for all of us, and that may be the paradigm shift that we go to.
Well, thank you for that. Now, Commissioner, I've heard a lot of talk lately about premium tax credits. So can you explain to our audience what that is and what actions your department is taking?
The Department of Insurance recently approved a COVID relief filing for individual dental policies. And one of those policies happened to be with the Guardian Life Insurance Company of America. And that proposal specifically included a 25% discount for both June and July of this year on premiums, for a total discount of 50% of a month's premium. And they gave a 90-day extended grace period to pay your premium with an option to pay the unpaid premium over a 12-month period. In other words, if you were behind, they'd split it up and let you make 12 payments and get caught back up. And there was an increase in coverage for the remainder of 2020. So they've done a lot of things to be helpful to the consumer. United has been a good corporate citizen in trying to take care of their policyholders as a provider, and I know they're pretty big in North Mississippi, so that's probably good news for where we are in North Mississippi. We had some other relief that United Healthcare gave out through AARP. It's pretty important. That specific reduction is something that we didn't have to approve. It's sold nationwide, so that worked out quite well for us. So additionally, we'll have some other carriers that have followed suit. Unfortunately, one domestic carrier here has not done anything, but we're on them to try to get something done.
Well,
I thought you'd enjoy that.
Hopefully that will take place. Well, Commissioner, House Bill 95 recently passed the Mississippi legislature. What exactly does that bill do?
Well, House Bill 95 is a bill that deals with balance billing. We already have a bill on the books, or a statute on the books in Mississippi that says that a healthcare provider cannot balance bill if they take an assignment of someone's health insurance benefits. So if someone came into the hospital or emergency room and they took an assignment of the health benefits at the hospital or emergency room of that patient, they could not send that patient a bill for or more than what that insurance company would pay. The problem that we ran into were some abuses, not in North Mississippi, but we had some abuses by some providers where they would balance bill or send a surprise bill. That's what we often call it, to the consumer, and the consumer would call us and, hey, I went to the emergency room and gave them my insurance card and they saw me, and that was 3 weeks ago, and I just got a $10,000 bill in the mail for going to the emergency room. And that's usually from someone that has a doctor on contract, and that's not allowed. You know, even if they're on contract, they're in that network at that hospital. So we had to work around that, and this gives us some teeth to. And I really didn't want it, but we had to have it, some teeth to try to enforce balance billing issue. We had a lot of issues with air ambulances, where our air ambulances would go pick someone up, and I'll give you a quick example, and take them to a hospital or a healthcare place, and to pick them up on the interstate or wherever they were located, and charge them $50,000 or $60,000. We had a recent case here in Jackson area where actually an employee of the state was flown 12 miles in a helicopter, and the state health plan paid $18,000 to the air ambulance for providing transportation for 12 miles, pretty high. And then 3 weeks later, the same patient got a bill from the air ambulance carrier for right at $21,000. And immediately they happened to know me, and they called me, and I said, Bob Williams can handle that. That's easy. And immediately it took us about an hour to get it straightened out. They were not billed for that $21,000. It's not allowable. Now, the air ambulance folks said, well, we can do what we want to because we don't fall under your purview. We're under the FAA. We say, fine, you fall under the FAA for the transportation cost, but you have to justify, and you can't justify $40,000 of transportation when I can run a plane and fly to New York City and back for $5,000. But I regulate medical providers that are on that aircraft, and you cannot balance bill. It's just that simple. Get it right or get out of the state. We're screwing the consumer. Part of the model that we have, the feds are looking at now, instead of trying to go to arbitration on every case, of saying it's got to be reasonable and within a balance. And Senator Wicker's office has been working with us to see how we've handled this, because his office at one time had preferred an arbitration on every case. That would be impossible for us to do at this department with 81 people total in the department. We'd have to hire $800 if we did that, 800 more people. So we've worked through most of that problem, and I could talk all day about balanced billing because we get a lot of complaints, but they've gone to zero. Let's just say that. And we don't have that problem today, and this law has only been in effect for about 2 months. Does that help you any?
It does. Thank you for that update. That was great information. Well, shifting gears a little bit, let's talk about the CARES Act. Tell us a little bit more about that act.
Well, the CARES Act, as most people know, the CARES Act dollars that we call it the Coronavirus Aid, Relief, and Economic Security Act. That's how CARES came out of it. That's a law intended to address economic fallout of COVID-19 and the pandemic in the United States. And it includes provisions for health care, relief to businesses, and relief to individuals. And up to $15 billion from the CARES Act was provided to providers that particularly provide health care services in the state of Mississippi, and that's Medicaid and the CHIPS program. I am working very quietly with a task force on rural health delivery, and I will say that the University of Mississippi Medical Center is trying to address that through their telehealth program. But if you can imagine a line from DeSoto County down to Jackson, just take I-55 and go everything west of that, with some exceptions, you've got most of rural Mississippi. And that's the Delta, and people have to drive over an hour sometimes to see a doctor. And if you're in the healthcare business, and as a regulator, I have to say that you have proper medical access. In the rural areas, it's 1 hour or 60 miles. And there are borderline cases and that people do not have access to medical care. And that's why telehealth is so dead-gum important to us.
Commissioner, can you talk to us a little about how the insurance department may have issued bulletins to assist consumers during the pandemic?
Well, I can. We issued another bulletin. I said 2020-1 was telemedicine, so 2020-2 was a bulletin. I recall signing that on March the 23rd. And basically, what that bulletin does, it addresses the audit expenses that many of the carriers would have. In other words, they could go back and self-audit and this affects things like commercial insurance and lower their premium. A casino, for an example, on the Gulf Coast may say we project ourselves to be $1 billion this year in the casino business, so our insurance would be based upon those sales. We have COVID-19 and the sales dropped, say, to 500,000. They could reduce their insurance by 50% because it's a self-reported audit. It's a way for them to say our sales are down 50% and we'd like to adjust our insurance premium. And that's usually workers' comp and some of the other issues that you have on liability. So that's been very helpful. And then we issued Bulletin 2020-7, where people that have been quarantined or who have been practicing social distancing in MAD is aware that they have been doing that. As a result of these necessary actions, companies in the state may be able or unable to renew their licensing or their registration. And people do not realize that the Department of Insurance issues over 600,000 licenses a year. It's mind-boggling. And you have well over 100,000 licensed agents, and we do a little over 500,000 of what we call COA, certificates of authority, which are licensed to do business within the state. So what we've done is we've changed some of the way that we do the licensing. You can do it online for the consumers that are agents that have to take educational courses. You can do that online, and we've stopped some of the testing that where you can do that online with a proctor. And that's really, that may be the new shift that we go to. It saves a lot of money, not only for those people that have to have a license, but it saves a lot of exposure during the pandemic. So those are a few of the things that we've done. And we made it a lot easier for adjusters to get their license fairly quick. with Hurricane Sally that looked like it would have hit the Gulf Coast. We had to have emergency license ready to issue to adjusters that would come into the state. So we worked hand in hand with Alabama. My good friend Jim Ridland is the commissioner there to issue our emergency license for adjusters. So that's just some of the things that we've done during the COVID-19 epidemic.
So, Commissioner, there was recent activity on the Mental Health Parity Addiction Equity Act. And can you tell us what the state of Mississippi is doing to assist those individuals that might be in need of mental health assistance?
Well, the Mental Health Parity Act, and that's another one of these acronyms, it's the Mental Health Parity Addiction Equity Act, required health insurers as well as group health insurance plans to guarantee that financial requirements on benefits, including co-pays, deductibles and out-of-pocket maximums, and limitations on treatment benefits for mental health or substance abuse disorders are not restrictive or more restrictive than medical and surgical benefits. Now, let me tell you, I've been a stickler about this, and my staff will tell you, I'm a big believer in mental health parity, and we've had a couple of health insurance providers that didn't want to do mental health parity, and we've hammered them pretty bad. They're doing mental health parity. That's all I want to say. So we were awarded the Health Insurance Enforcement and Consumer Protection Grants back in October of 2016. And the primary focus of those grants was to create a compliance review process to ensure insurance carriers are in compliance with the laws, such as the Act, as we call it, and as well as to educate Mississippians on their health care benefits. And this has worked quite well. We've got accolades from CSIO, CMS, and HHS for that work. So people, let me tell you, mental health is important, and we're making certain that if it's a reimbursable expense, the insurance companies pay for it.
Well, Commissioner, thank you very much. We appreciate all your comments today. You got any final thoughts that you want to share with our audience?
Well, I appreciate the good work that y'all do to try to keep your providers and all of your staffs informed about the ever-changing world of healthcare, especially in the insurance side. We're here to help you. You can always contact us, and I throw this out all the time, at www.mid.ms.gov and ask for Bob Williams, and that's 1-800-562-2957. If you have a telephone you want to call and speak to a live human being, we're there. Ask for Ryan or Andy in that case, 1-800-562-2957.
All right, sir. Well, thank you again for your time, and stay safe during the pandemic.
Thank you, Wally. Should I put my mask back on at this point, or are we still far enough apart?
I think we're okay at the moment, but now if you head out of the building, you may want to put that on.
Thank you. You have a great day out there, guys. Appreciate you.
Thank you, sir.
We wanted to pause and take just a minute to recognize some very courageous individuals, our North Mississippi Health Services family, and especially the nurses, the physicians, and all of our team members who are taking care of our community members each and every day. Join me for just a minute as we recognize our heroes.